Neither the El Paso County Medical Society, its members, nor KCUS TV shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
Pop in a second, but there you go.
Hello.
We're live.
Hi. So we are live, and this is what happens on live TV, right? There's traffic in El Paso. However, we're going to have a really, really great traffic system pretty soon, right? Hi. I'm going to talk a lot about you. Anyway, we are here with the El Paso physician. Thank you so much for joining us this evening. Have we gone to the opening yet by chance? So let's go ahead and go to the opening, and we'll get ourselves situated. Good evening. Sorry, usually the opening's on at this point. Hello, thanks again for joining me. I'm Catherine Berg, and you've been watching the El Paso Physician so far, and you can make some fun of me for two different reasons, because I have the complete wrong list of doctors with me as well. So I am going to ask for the show to send over to me the new list. We've had, actually, I'm going to do a little funny thing here. Dr. Henry Garcia. I'm going to talk about you until we get the show really going.
Okay.
I have a 16-year-old boy who's happy and healthy because of you, and I thank you for that.
You're welcome.
Oh, thank you very much. I know that lots of moms tell you this throughout the days and throughout the years, and kids probably come to you and have no idea what all that you did. So I had some difficulties in my pregnancies, and you really helped me along with that, so thank you very much.
You're very welcome.
And I would love, if I could, get the names of every other doctor on this panel. Do you guys have that by any chance? So in the meantime, tonight's show obviously is going to be focusing on wellness care prior to birth, wellness care during and right after birth, and then there's pediatrics that go from there going forward. Yeah, if I could take that, that'd be awesome. Thank you very much. And so we have Dr. Henry Garcia, as we just talked about. We have also Dr. Saldivar, and he also is with Jorge Villarreal, and all of you are OBGYNs. And I know that sometimes we have programs that show what the OB doctors do, what the GYN doctors do, but we're going to talk specifically tonight about babies. We can talk a little bit about the making of babies, in that there are people that have a hard time conceiving, and I feel like that's something that we don't talk enough about in our community. And on that aspect, I would like for you, Dr. Garcia,
Sure.
to explain to the audience kind of that time of what do you do all day, every day, compared perhaps to what the other doctors on the panel do.
Okay. Well, as far as, so I'm a general OBGYN. And so a general OBGYN does gynecology as well as obstetrics. And whenever we encounter difficult cases or situations, then we obtain the consult and the help of subspecialties within OB/GYN.
Okay.
There's some subspecialties which will include maternal fetal medicine or perinatologists, which are for high-risk pregnancies. We have gynecologic oncologists, which is what Dr. Saldivar is, which just deals specifically with cancer, and GYN cancer. And we also have reproductive endocrinologists and infertility specialists, which just deal with infertility, but infertility that it cannot be handled by a general OBGYN. I can actually present a case. I just delivered a patient yesterday, very interesting case, where this patient came to me for infertility, and when I started talking to her, she was 36 years old.
Okay.
She had a history of irregular cycles, and I was just a little suspicious for that, and so I went ahead and completed the evaluation. So whenever somebody comes to you, not only for infertility, you got to obtain a complete history and physical, try to evaluate, make sure they don't have diabetes, hypertension, medical conditions that can go on and affect a pregnancy.
Right.
This patient had irregular cycles for a long period of time. So I went ahead and did an endometrial biopsy on her.
Okay, good.
To rule out cancer. Although it was a low suspicion because she's young.
Right.
She did something about her just gave me. So she did come back with endometrial cancer.
So I have a question, and I do want to talk about endometrial cancer and also endometriosis. How is the biopsy performed? Is it a vaginal biopsy that you go in?
Correct.
Okay.
You perform it in the office. You obtain, there's no, you can have the patient take a non-steroidal before the procedure to help with some of the cramps, but it's a quick procedure. It takes maybe 5-10 seconds to do.
Okay, 5 or 10 seconds to do.
Correct.
Okay.
So it's
if
fast.
you were going to compare that to a pap smear, and the reason I'm saying that, is that anyone over the age of 18, más y menos, I say anyone, most women over the age of 18 at least know that sensation. But I'm thinking maybe the procedure and the prep up to that, and I know it's very different, but at least that's something that the women in the audience know. So taking it from that step going forward.
So so on a scale of 1 to 10, 10 being the worst, a pap smear saying it's a 2, this will probably be about a 7 or
Okay.
8.
Okay.
But it's quick.
Okay.
It's quick.
It's quick. I love that when you said 10 or 15 seconds. That's nice.
Yeah, and so
Okay.
this endometrial biopsies can be used postmenopausal women that have irregular cycles. That's what the gynecologist will need to do an endometrial biopsy to rule that out.
Okay.
So just to finish the story, so I went ahead and took so she came back with endometrial cancer. She's never had kids, and so I referred her to Dr. Saldivar, and
Okay.
I'll let him take over from here because this
perfect.
is a very interesting case.
And I love this. Case studies to me are the most interesting because we can actually follow what you all do and as a team, what
As a
everybody
team,
does.
exactly.
And that's really what we try to focus on here. Dr. Salvador, so from there, you now have this patient in your care. And again, the team's still around, but where do you go from here?
So there are various criteria that, at least in this patient, that we took prior to treating her conservatively, just because she's not had children.
Okay.
And one is using progesterone, which is opposite of estrogen. Endometrial cancer tends to be, the majority of them are unopposed estrogen or estrogen-dependent tumors. And so one of the ways, one of the novelty ways of treating it is with an IUD, a Mirena IUD, which is progesterone.
Okay.
And of course, they have to meet certain criteria. It has to be a low-grade tumor, not a very aggressive one. Then there should not be any invasion, and we get that through an MRI. And then you leave that in for 6 months, and you reperform the biopsy in the office.
Now, when you say invasion, what do you mean? Invasion of where the tumor is or the UDI? Or when you're talking about invasion, what are you talking about?
So if you think of the uterus as let's say a pear,
Okay.
the lining, the inside of the pear is the lining. It's called the endometrium, and the actual fleshy part of the pear is the myometrium or the muscle.
Okay.
So as long as there's no invasion into the muscle of the uterus, then that's one of the various options of treating endometrial cancer.
Okay.
And so we did in this case, we put in an IUD, and then
So how long ago was this? For example, how old was
Yeah,
she
she
going
was
in? How old?
36.
Okay. Okay.
So we'll continue with the story. So Dr. Saldivar,
I remember that face when we were together, Dr. Garcia. So let me continue. Okay.
So then I don't recall exactly, it was 6 months, and the tumor regressed.
Okay.
In other words, we got a biopsy that did not show any endometrial cancer. And then I think she went to you.
yes.
That's-
So remember that endometrial cancer is traditionally treated surgically
Right.
and traditionally treated with a hysterectomy. So I thought her chances of getting pregnant were over.
Right. Exactly. And that's
So
where I'm going
this
with
is
this. Yeah.
incredible with
Yeah.
Dr. Saldivar. So she came back to me and I said, look, I'm sending you Dr. Noble, who's a reproductive endocrinologist and fertility. And he went ahead and just went straight to in vitro.
Okay. Straight to in vitro right after this procedure.
Correct.
Wow. Wow.
Well,
Okay.
some years went
Okay.
by here. So
Okay.
So then and then she came back and she delivered a healthy boy. She's now 40. She delivered a healthy boy yesterday. 9 pounds, 15 ounces.
Yesterday. Is she watching? Does she know you're on
She
the air
knows.
now?
She
You don't
got.
have to say hi, but
Yeah, I got her permission to present this case.
yeah.
Yes.
Okay. Well, we didn't
So-
use your name, and we're not gonna. But congratulations! Now
So-
becomes the sleepless nights, right? That's when it all. Congratulations.
Well, congratulations to the whole team.
Well,
So
My
this
goodness,
is
and this
what El
is-
Paso offers. This is what we have in this community, which is cutting edge.
right.
It really is.
And that's something to, again, just looking at several years back, to find endometriosis, people thought, okay, well, that's it. I'm infertile. There's not even a chance anymore. My daughter, who's 22, she thinks, oh, Mom, I've got all these issues. I'm going to be infertile. But there's so many things on the horizon, really over the last decade, and also still on the horizon. And the joke is, the 40 is the new 30, the 50 is the new 40. There are children having children. Fine, but then there are old people having children, and that's fantastic. And Dr. Villarreal, I'd like to kind of bring that to you. Just this was a case study, but in your years of practice, what has really been on the forefront over the last 10 years, where we hear often now that 40-year-olds are having babies, 45-year-olds, not as often, but it's becoming more and more real and common. And why is that?
Absolutely. Well, because I believe life is longer, and human beings were living longer, and family size is getting smaller. If you just look statistically, in the 70s, average family size, even in Mexico, was 7 per household. And I think in 2010 it was 2.2.
Wow.
And I believe in
Okay.
2020 it's probably going to drop below 2. So there's not that pressure to have a large family. But that leads to reproduction problems.
Right.
Yeah, because us human beings, we're most fertile when we're in our teens, and we don't want teenagers
Yeah, that's
having
the
children.
babies having babies.
Yeah,
right.
so
right.
that's one of the main reasons that we see more infertility cases. For instance, a couple in their 30s, average time to conceive is 6 months.
Huh.
Yeah, that's average.
Okay.
So that can lead to frustration.
So when you say average couple in their 20s, then would be 2 months to conceive if they're trying, if they're saying we're not using any birth control.
Somewhere in that time frame,
Okay.
2 to 6 months.
Okay. And this is with Dr. Garcia here. I mean, I was 30 when I had my first little one, and she was honeymoon child. But because I was 30, we stopped using all birth control, and I thought it's going to take us a year or 2 years. And so we were very lucky with the first one. The second one took forever and a day.
Yeah.
So that's what this conversation comes into. But still, it's interesting to me about what is it that women are doing? Yes, we're living longer, but is it just maybe the general idea of we're more apt to eat healthier, we're more apt to look around and say this is the way to be healthy, and I'm just throwing out to anyone who would
For
like
fertility?
to take that. For fertility, exactly. For being able to have children, because really, think about, let's say my mother's generation. I'm 52, my mother's generation would be 75-ish. For someone to have a child at 35 in that time frame, or even at 40, was almost unheard of. Is it just because it was a taboo? Is it because, what is it now that's so different with our bodies that make it easier to have children at later ages?
It may
Doc-
not, well,
Dr.
it may not necessarily be the bodies, but the whole, women are in careers now, and they're putting off families at a later stage.
Right.
I think there's more awareness because of any social media.
Yeah.
And there's more awareness with respect to finances, perhaps student loans in certain young women that they want to put off the family towards.
So those
towards
are all
later in life.
behavioral
Yeah.
lifestyles that we're looking at. And I'm just, in my head, I'm just thinking about,
Health.
and I don't mean to be too bold to say this, but people are not having less sex or more sex now than I would think a century ago or 2 centuries ago. Maybe they are, I don't know. But even the accidental pregnancy at the age of 50 is something I wouldn't have heard about when I was a kid. But now I hear about pregnancies when people are 50, and it's like, not common, but it's not that big of a deal. I guess it's just kind of interesting altogether how the world of health works in that area. Let's go to, because this is an OBGYN show, and I'd like to kind of go back to the beginning, and I talked about just having pap smears in the beginning. Let's talk about just a general office visit right now of a 25-year-old girl that goes in for her regular exam. And let's say that she's in the conversation mode of maybe having babies now. So I'll start with Dr. Garcia. So she goes in, what does she expect? And let's say she's been several times before, but let's say this is her first time to go in for an annual exam. What is she to expect? And then she's going to sit down and talk to you about, well, my husband and I were thinking about having kids. How does that conversation go?
So that's important. Actually, for any well woman exam, if you're talking to a woman that's in her reproductive years, we should always ask if they're going to try to get pregnant or if they're thinking about getting pregnant within the next year, because that does initiate a different conversation. You know, right now she could be on birth control pills, and so we could definitely talk about fertility issues related to that. So if they're on a birth control pill, certainly going to want to stop the birth and start maybe folic acid, prenatal vitamins. Folic acid has been shown to reduce the risk of open neural tube defects. If taken, so open neural tube defects are like spina bifida, anencephaly, just a problem with the closure of the neural tube, which happens in the first 28 days of life.
The first 28 days? 28 days.
Goodness. So many patients don't even know that they're pregnant.
Right.
And so that's why it's so critical to be on folic acid for at least maybe 3 months before getting pregnant. So that's something that we would address. So we would also look and talk about in the history if there's any family history or any personal history of certain key problems that could affect the pregnancy. So we're talking about hypertension, diabetes, autoimmune problems, problems related to mental health, problems related to thyroid dysfunction. So all those are key medical conditions that we definitely want to address.
No, I was just going to say, and I just wanted to go along with the panel here, and I was not one of those good people that went every year because, you know, there's insurance and you're young and you don't know, but I am hypothyroid, had no idea until I was pregnant. It's like, man, I'm just tired all the time, and the little What You Expect When You're Expecting book says, well, you're climbing a mountain every day, but it's a beautiful time to get all these tests done. But directly to your point, that even if you're in your 20s and you haven't gone yet, just go to get a baseline of everything that needs to be done. Get a pap smear done. It's also a great place, and I know this is not a breast cancer show, but within that annual exam, you usually have your breasts checked, and if there are issues, then go. So I guess one of my ways of saying to you, the audience, that if you have, this is an older skewed audience, which is good, and that's a compliment, but when your grandbabies haven't gone yet, if you have a 20-year-old, 22-year-old that hasn't had their annual checkup yet, find an OBGYN and get that done so that this conversation can start. You want to see what your body's doing, what shape it's in before you start thinking about having the little ones. Dr. Salvador, I'd like to talk with you a little bit about, so we've gone to, let's say 25-year-old, she's doing well, we're trying to get folate, she wants to get pregnant, etc. Now we have, for you, we have the 35-year-old who's never been pregnant, didn't expect to get pregnant, but she shows up at your office, she's pregnant. And let's say she's 3 months pregnant and hasn't had any visits, and it seems like everything's going fine, but just in general, when you have that patient in front of you, what is the conversation you have with that person?
So I do GYN oncology. So most
that's all right. You're oncology.
Most of the patients.
Okay, well, let's say this person's pregnant. She's 35. It's her first pregnancy, but she also has ovarian cancer, some kind of a pelvic mass.
Just to kind of, so I did, and this is another patient we just delivered recently. But I had a patient that I did an exam. I did a pap smear. Her pap smear came back abnormal. It came back, so I took biopsies. It came back severe dysplasia, and she had extensive severe dysplasia.
Oh my goodness!
She had never had kids. She unfortunately got pregnant before she underwent any treatment. So now she's pregnant. She has severe dysplasia. So I referred her to Dr. Saldivar to start undergoing frequent colposcopic examinations, because when we're talking about microinvasive cancer as opposed to cervical dysplasia, we're talking millimeters. So you can take a biopsy here, and there could be invasive cancer right next to that, and so it could come back CIN3, which is severe dysplasia, but you can have cancer right next to it.
And not know.
So you need an eye like Dr. Saldivar has, and the experience that he has looking at cancer, cervical cancer,
Right.
to be able to make sure that that patient doesn't have that. So yes, he does see occasionally some patients that are pregnant.
Yeah. So maybe even we can take the pregnancy away, and because the world of biopsies is scary. You hear the word biopsy, and people think, oh my gosh, they're going to go in, they're going to take tissue that. I would, and that's why too I was talking about Pap smear and then going into, because it's a vaginal entry, etc. When you are biopsying patients for a mass that there is a mass there. You want to figure out what's there. What are some different types of masses that you experience? We talked a little bit about this one here, but we have endometrial mass, we have also ovarian cancer. That how does one know if they haven't had a Pap smear and all of a sudden does ovarian cancer cause pain when it's in an advanced stage? How do people know? And I know screenings is a whole different thing, but how do you as a doctor do biopsies on different types of cancers that may be existent?
Sure.
That's a loaded question.
Yeah, I know
it's
it
all
is.
over the place. I know.
So in short, there's three major cancers that we treat in gynae oncology. One is cervix. So as Dr. Garcia was saying, when a patient comes in, pregnant or not, and she has a mass on her cervix that hasn't been biopsied, then I proceed to biopsy a lesion on the face of the cervix.
Okay.
And that includes speculum exam, like
Right.
a Pap smear,
Right.
and then taking the biopsy of the visible lesion, or else we use a colposcope, which is a microscope that gets close to the cervix, and
So this
in
is
brief,
human eye looking at a lot of this too.
human eye
Okay.
with a special filter.
Okay.
Yeah, on the colposcope, and once you get that biopsy, then send it off for pathology, and then we manage accordingly, whether it's pre-invasive cancer, as he was saying, cervical dysplasia, which is, I don't like to use
So
the word
cervical
pre-cancer.
dysplasia, if you were to describe to me as a second grader what cervical dysplasia is, what is that?
One analogy that I use
Yeah.
with my patients is like a scrape when you fall on your knee. Just
Okay.
a little scrape, and it looks red. There's abnormal vessels. It has a certain look to it under the colposcope.
Okay. So when you see it, your eye pretty much knows what that is, and then obviously you get a biopsy
The
right there,
majority of
but
the
you
time.
pretty much know what's happening.
Yeah,
here.
the majority
Okay.
of the time.
Okay.
Yeah. For endometrial cancer, which is the most common GYN cancer that we have, and that's because of obesity, unopposed estrogen in general. Again, just
Right.
for those we do, like we were talking about earlier, endometrial biopsy. Whether it's done in the office or if the patient can't tolerate it, we can do it in the operating room
Okay.
with various instruments. We can put a little pipette, which looks like a straw, inside the uterus, or a hysteroscope, a camera, and then do a scraping or a biopsy of any lesions that are in the uterus.
So when you were talking earlier, Dr. Garcia, about almost immediately the fertilization was happening. So you were talking about there's a year time span from this patient that just had her baby yesterday, right? Endometriosis, treatment, and now we're going to try to get pregnant.
Well, this was endometrial cancer.
This is endometrial
She had
cancer.
endometrial cancer.
Okay.
So endometriosis is a benign condition
Okay.
that can cause infertility and severe pelvic pain
Okay.
and pain with intercourse, but it's benign.
But it's benign. So there's
so
not.
this is endometrial
Okay.
cancer
same.
that we're talking about, which is,
Could it be a
significant.
precursor to cancer?
No.
Okay.
Endometrio-
Completely a separate
endometriosis is
deal.
Separate. Won't
Completely a separate
cause
thing. Okay.
cancer.
So, guess what, Dr. Villarreal? I get to talk to you about endometriosis. It's always a hard thing to say.
Endometriosis.
Not in the world of oncology. Now we're looking at, and do we have a percentage of people, of women that have endometriosis that you might know? And it's even a más y menos type thing.
Yeah, I don't think we have an exact number.
Okay.
What I can tell you is it's very common.
Okay, and that's what I feel like I hear, that it's all over the place.
Yeah.
And so Is there a cause for this? Is this just something?
Well, yeah, it's what we call a multifactorial.
Okay.
So it can be genetic, it can be hereditary, and it can be behavioral too, as we don't have as many pregnancies in women nowadays.
Right.
So the best way to avoid endometriosis is start reproducing when you're 15 and not stopping until the end of reproductive life, which we don't
So
encourage
having
anymore.
pregnancies and having babies is
And lactation,
helps.
breastfeeding,
And
yeah.
okay, so all of these, and is it the hormones that are helping with
Yes.
keeping?
Those
okay.
women are anovulatory. They're not ovulating.
Okay.
So when a woman's ovulating, the cells from the lining of the uterus, which Dr. Saldivar was describing,
Okay.
can go to other places.
Okay.
And sometimes they'll go through the tube and go into the pelvis and cause issues with infertility, pain, bleeding.
Right.
Yeah.
So women who are on birth control pill, it prevents them from ovulating. Is that correct?
Correct.
So that's also a
That's a
risk factor.
No, it
Or it's
actually
a s-
protects them.
Okay, tell me why. So
because
that's
they're not ovulating. It's
okay
suppressing
because
their
they're not
ovulation.
okay.
Right.
So the pregnancy is also you're not ovulating. That's what helps. So anytime the ovulation occurs is where there's a little bit
With
of a
the
rise.
menstrual cycle, every month that endometrial tissue close to menstruation gets thicker and prepares for implantation of the fertilized egg.
Mm-hmm.
So you're stopping that, in essence, with the contraception.
Okay.
Yeah.
Now that makes a little more sense. And again, when you were talking, I don't know if that would have been as common 100 years ago. We're talking about a century ago. A lot of time in this program, I talk about, a decade ago, and women have been having babies a really long time.
Yeah.
Thank you for laughing at that. Question here from the audience. So this is the disclaimer. This is all the information that we have from the audience. So this is all we have to go on. There is a disclaimer at the beginning of the show that if you give the wrong answer, you will not be sued. So we do the best that we can with whatever we have.
Good Samaritan.
Exactly. It's the Good Samaritan law. That's what we do on this program. What are the chances, and by the way, on the questions, I want to stop for a second. We are, and have been really for the last 6 months or so, been streaming live on Facebook. And that's beautiful because you can ask your questions on Facebook. If you're not around a television set, if you happen to have your phone with you, or if you happen to have one of your iPads with you or a tablet, you can ask your questions live on Facebook as well, and also at 881-0013. Question from the audience. What are the chances of developing ovarian cancer in a 67-year-old woman who had a hysterectomy in her 40s? And since you're oncology doc, that one's going to you. So I'll repeat it. What are the chances of developing ovarian cancer as a 67-year-old woman who had a hysterectomy in her 40s?
Okay, so a hysterectomy, the uterus has been removed, and because she was in her 40s, more often than not, her gynecologist left the ovaries in place.
Okay.
So
So tell me, because she was in her 40s, why would that be? Is that the release of all the all the-
estrogen,
okay, all the
estrogen,
hormones,
yeah, to
okay.
keep the estrogen in so that they don't go into menopause. Because estrogen, without any other issues, it has more benefits than risk if they stay in, if the
Okay.
ovaries stay in. Now, 67-year-old with a hysterectomy and no other issues, no pain, no bloating, any early satiety, weight loss or weight gain, swelling, things like that, frequent urination, constipation. Without any of those symptoms, the ovaries are likely normal.
Okay.
And again, I encourage them to get their annual exam with a pelvic exam because they still have their ovaries in place.
Okay.
One of the things that I want to stress though, and I know we were talking about, or Dr. Garcia was talking about, a young woman coming in to for a general well-woman visit. One of the things that we look at specifically is family history.
Right.
So if they have a family history of ovarian cancer or any other cancers in clusters, endometrial cancer, colon cancer, breast cancer, then we start investigating a little bit more. And at least in my practice, I'm a little biased. So if they come in with any kind of symptoms, I perform a pelvic ultrasound and to look at those ovaries.
Why not?
Yeah.
Exactly. I would agree with that. And I know it's a whole nother show, but I feel like, and this is where it is a decade ago, about a decade ago, there was a lot of genetic testing, and that kind of started out in the world of breast cancer, and then it kind of became female cancers, and then others now too. And I know we've got one oncologist on the show. So maybe think about, I always stop the show about 10 minutes before we end for things that you all would like to say that we haven't gotten to yet or that we haven't been able to expand on. But I'd love to talk a little bit about that with female cancers that aren't necessarily breast cancer and just genetic testings. I feel like, and we talk to the medical students all the time, that this could be on the horizon. I see Aaron over there. Who is that? Heather? Heather and Aaron? Heather and Aaron are over there. Hi guys. Have you ever seen me this not put together on a show? Goodness, what? So it's just kind of interesting, but that to me is the whole genetic world in the upcoming decade is going to be fascinating. Question here from the audience, and Dr. Villarreal, just because I haven't talked to you in a while, you get this one.
Sure.
Is bacterial vaginosis related to having an IUD is the question from the audience. Again, that's all I have here. But, but look, the other two said, hey, that's a good question. You got a good question. Isn't that grand?
Yeah. Well, bacterial vaginosis is a catch-all for a change in a woman's normal vaginal flora.
Okay.
And all human beings, we have a lot of bacteria on us. And a lot of times, the bacteria looks like it's an infection, and it's really not.
Okay.
And I guess if there's an IUD there, it could cause an irritation to maybe change the flora a little bit.
Okay.
Doesn't necessarily mean that it has to be treated. You would treat it if there were symptoms. But if there's no symptoms, it may not even be an infection. It could be her normal flora.
Okay. Her normal flora. I like the way that's said. I'm going to bring that now a step further because there are some women that have yeast infections all the time, other women that don't. So expanding on what's normal for some and not normal for others, what is it that can cause, and I know it's such a simple question to you guys, but to the many women out there that either have UTIs all the time or yeast infections all the time, and I'm throwing that out to anybody, but I'm going to have you start with that. Yeah. Because normal flora, I like the way you said that.
That's a very good question because you have to make sure there is an infection.
Okay.
One of the most over-treated conditions in the United States is UTI. So
Really?
A lot of, yes, absolutely.
Okay, so you have to make sure that there's an infection.
There's an infection. It could just be an interstitial cystitis or an inflammatory process.
Okay, explain what those two are for the audience at home. So if you have a cystitis.
It's an inflammation of the bladder.
Okay.
But it's not necessarily an infection. And it could
But
be
the
related to
symptoms feel-
endometriosis, which we discussed earlier,
Okay.
of those same cells going to other places in the pelvis.
So if someone is feeling symptoms and they think they have a UTI, what are they feeling? What are they feeling? And I know, again, it's different too. And it's men and women, but mostly women that have UTIs. What are the symptoms that they are feeling? On when should they think, I wonder if this is time to really go see my doctor about this? Is it, do I just wait for this to go away? Again, all three of you, you're welcome to just chime in. But
Yeah. No, they should be checked.
Okay.
But the diagnosis has to be correct.
Okay.
So you have to get a urine sample if she's had a change in her urination.
Okay.
A painful urination or a more frequent urination, something that's just not right. She should see a physician.
Okay.
But just to make sure that the diagnosis is correct.
Okay. And then from there, and Dr. Henry Garcia, I'm just going to bring it to you. I can't call you Dr. Garcia. You're like Dr. Henry Garcia. I don't know why. It just keeps coming out that way. So let's talk about treatment now. So now we have someone who does indeed have a urinary tract infection. But let's talk about treatment of that. Let's talk about treatment of yeast infections and the bacterial
Vaginosis.
Okay, bacterial vaginosis.
So the key, and so as Dr. Villarreal mentioned, it's very important to get a correct diagnosis. And so the way I see it, you have to have a positive urine culture.
Okay.
So urine culture is key. I see patients coming in from the ER, getting treated with antibiotics, and the problem. It's great to have urgent care centers, and it's wonderful, but they don't necessarily go that extra step, and they can't.
Right.
I mean, they don't follow up patients with a urine culture. And so the patient keeps going back to the urgent care because of painful urination. They're given antibiotics. It's just an empiric antibiotic, and they're not treated properly. Because if you get a culture, you'll be surprised, and I know that these docs can attest to it, how many, what these bacteria, are resistant to. So you have a lot of resistance out there. Antibiotics that we used to use that would, in the past would say I've never seen resistance to this particular antibiotic ever. Suddenly we're now seeing some resistance to these antibiotics. And so
is it because it's being used,
probably,
that antibiotics is
for
being
sure,
used a lot?
For sure,
Okay.
it's just not, it's overuse of certain antibiotics. It's
Okay.
treating without a culture. And so all that's very, very important. So the diagnosis is important. Treatment of bacterial vaginosis is usually either oral or with an oral antibiotic or with a vaginal antibiotic.
Okay.
Just to go with the treatment of bacterial vaginosis. Unfortunately, once you have a case of bacterial vaginosis, it can be recurrent, and sometimes up to 60% of patients do have recurrence of bacterial vaginosis. So it sometimes is a frustrating condition to treat. Now, every once in a while, we'll do a pap smear and we'll see bacterial vaginosis come back on the pap smear result. That patient's not symptomatic. Whether you treat that patient or not, it's up to you. But really, patients should just be treated if they're symptomatic, in my opinion.
So I love, and this kind of goes in correlation with the two of you, and it may or may not be appropriate depending on who's watching and who's listening and what the opinions are, but we have Juarez right next door. And we've had programs before too, speaking about antibiotics, speaking about resistance, and it's so easy to get medication that's not prescribed. And I'm not looking at you just for a minute because you're oncology guy. But in general,
I treat those too.
Okay, then bring this conversation in.
I'll take let these guys
Or just when you have patients coming to you and they're like, well, I've been taking Pinvex or whatever from Juarez now for a month and a half and nothing's going away. How often is that still as big a thing as it was years ago when I was a teenager? And I remember we came from Germany and I used to get strep throat all the time. But then there's bacterial strep throat and viral strep throat. And my mom was like, well, the people from Juarez, I got these from work, just take these. We didn't know any better. So I feel like when I was a teenager, antibiotics were everywhere from Juarez. Is that still a thing? Is there any regulation now? I'm throwing that question out to anybody because you get it. Because you know what, you're like chopping at the bit.
Well,
we're over-treating.
Over-treating, and there's a placebo effect.
Bingo,
with
that's an
antibiotics,
excellent point. That's an excellent
and so
point.
when you were being treated when you were 15, you probably had tonsillitis, and most likely it was either viral or allergic. And and it was going to go away whether you took anything or not.
Right.
And you took the pills, and they made you feel better, and that's why they were prescribed.
Right.
But I think our colleagues in Juarez, they're doing a better job now.
Okay, good.
Okay, we don't see the rampant antibiotic use that we used to.
And I'm not even talking including the doctors. I'm talking about just going to a pharmacy on your own as a non-doctor and just getting antibiotics over the counter. That's the population I'm speaking about.
Yeah, and that's still available.
Okay.
Like I just saw a pregnant patient that she was placed on ovules that had an antibacterial in them, an antifungal, and a steroid. It was basically shotgun medicine, destroy everything you can in the vaginal area, which you probably should not have. We don't even have those products in the United States.
And she was pregnant, so
she
it's
was pregnant,
bad to
right.
mess with the system
And
when you're pregnant.
It was made by a major pharmaceutical company, an international pharmaceutical company.
Okay.
Yeah.
Yeah.
So we still have that.
We've got that issue still. You're welcome to hand me questions. Thank you very much. Question here from the audience. 48-year-old woman who had a total hysterectomy, everything but the cervix, so ovaries are gone, 8 years ago, and has been on estrogen replacement since. So again, at 48, estrogen replacement, so she's 56 now. She was recently diagnosed with endometriosis. Again, so that makes me think that she had it before as well. Should she restart estrogen therapy after it is removed? I guess after she has surgery for endometriosis. And I'll read this again because there's a lot of stuff going on here. So, and whoever wants to take it, and again, piggybacking is fine. A 48-year-old woman had a total hysterectomy, including ovaries, 8 years ago. She still has her cervix. She has been on estrogen replacement since. She recently was diagnosed with endometriosis again. Should she restart the estrogen therapy after it is removed? Again, question from the audience. Go for it. I love it.
She has suspected endometriosis. Most likely, the diagnosis has not been made.
See, you're good. You're good about get the diagnosis.
Yeah,
I
surgical
like that, right.
diagnosis. It has to be a surgical diagnosis.
Okay.
And if she should have the operation because of her symptoms, and she has endometriosis, yes, she could continue taking ERT.
Okay.
Estrogen replacement therapy. Yes.
So here is, again,
If
it's,
there's no
it's
other
another
contraindications,
loaded
yeah.
question. So I think 56, because I will tell the world, I'm in my menopausal time frame and I am taking a very small amount of replacement hormones, but I don't want to take them forever. I want to take them for a year or two, get the hot flashes out of the way, and then stop. So what makes me think here, so 8 years, she's 56 now, is there just a general time when to stop hormone replacement therapy? I know this is a hysterectomy, so it's different, but Dr. Garcia, anything in that world of conversation, feel free to talk about.
So 25% of women will continue with hot flashes forever. And so there are different ways to control hot flashes. Yes, estrogen replacement therapy is the most successful way of controlling vasomotor symptoms. But you also have non-hormonal ways of controlling
Talk to
hot
me
flashes.
about those, my friend.
So, well, there's a new medication called Brisdel, which actually is Paxil, which is actually used for anxiety. It's a SSRI medication, which is a serotonin uptake inhibitor.
Right, okay.
And so, but it's really that medication at a much lower dose. So really anybody that's on an SSRI will actually benefit, whether it's Zoloft or Paxil or a Prozac will benefit if their hot flashes will improve.
Good to know.
But that's what this medication is.
Okay. Is that, when I say relatively new, I always don't know how many years to throw in there. Is that something that over the last 5 or 6 years or so is being used a little bit more, or?
Well, this medication probably came out a couple of years ago, maybe 2 or 3 years ago.
Okay.
So
it's still relatively new. Okay.
And so estrogen also helps in other ways. It can help with vaginal dryness. It can help with bone health. It can help reduce the risk of osteoporosis. It can also help in some ways with collagen, your skin, and just some
all the
other,
soft tissues. You know, I just by nature of me being me, I read way too much on this stuff. But I do it on peer-reviewed medical sites. So I will say that. Don't just Dr. Google it. Make sure you're on a peer-reviewed medical site. But what I was reading about as well are just your arteries and your veins. You know, things become just a little less pliable as time goes on too, and estrogen kind of helps out with that. Is that something that?
Well, there's what maybe yes, maybe not. So it depends on when you start the estrogen. So if you start the estrogen replacement therapy right when you're entering menopause, say maybe, average age of menopause is 51, say maybe around 51, maybe.
Okay.
Maybe. But if you start at 65 or 60, it's going to actually increase your risk of cardiovascular events.
Okay. So on that note too, just visit your doctor, bottom line. And if you're taking hormones, maybe there's a time to see when and if that should stop, because then you're also looking at other risk factors, breast cancer and other female issues as well. So that's kind of a big one. I have still some questions here from the audience, but I also was just given the 13-minute mark, and because this is a show that you all can talk about all day, every day. Dr. Sandoval, I'm going to start with you. Is there anything that we haven't talked about yet? I know oncology and female, we could do 5 shows on that too. Is there anything that we haven't touched base on yet this evening that you'd like to get across to the audience, or even something you want to expand on that we haven't really done a good job on yet?
Yeah, we touched a little on genetic testing. Back in the day, we only thought that some of these mutations in, for example, BRCA, that we were just testing for breast and ovarian cancer, were in certain populations, i.e. Ashkenazi Jewish populations or certain Finnish populations. And they do exist for socioeconomic reasons in Hispanic people as well.
Okay.
Signature mutations that were in Jewish populations in a Hernandez and a Martinez.
Interesting.
Saldivar. I don't just throw
No,
it
and
out.
that no, I love that point because I had Dr. Regine Rivera on, but she's usually here in October, so she does a lot of breast cancer. But she was talking about the Ashkenazi Jew population, and she was specifically saying that she did the 23andMe test because she was just curious that you know you see all these genes, and little by little it's going to get a little bit better. And granted, people need to put their information into the system to be able to figure it all out. But it was fascinating to her, which made it fascinating to me. And I think again, 4 or 5 years from now. And then the question is, when do you test and when do you not test? You know, you usually want to test the person who has the cancer to see what they have, and then figure out if the descendants should be tested. I know that's a whole nother thing, but in your, I have not heard that Hispanics have a little bit more of a predisposition to certain types of mutations in genes. So that's new to me.
Not an increase.
Not an
it's
increase.
just that there are some signature populations that are Jewish in the Hispanic population.
Okay.
The point I wanted to make is that before we used to just test the BRCA mutation.
Right.
Now they're multi-gene panel testing.
Right.
And it's just not enough to just test BRCA1 and 2. Now there's panels up to 100 genes, and there's lots of companies that offer testing, and of course all the commercial ones like Ancestry and 23andMe.
Which, by the way, I want to say that's not a commercial for 23andMe.
Right.
Because it really is very small scale versus what you would be doing medically for a test. So I just want to I want to throw that out there and make sure that wasn't misunderstood.
Yeah. So now if and they're pretty cheap now. Before they were $3,000. Now they're like $25, $50.
I paid $100 for mine. It was a Christmas gift.
And they're
Dang.
becoming cheaper.
Well, the BRCA used to cost $10,000.
Oh my gosh,
Yeah,
really?
back before they ruled that you can't put a patent on our DNA. There was.
Might there be a day, and maybe it's already here, I don't know, might there be a day in your thought process and opinions where insurances might cover some of these genetic tests? I don't know if that's happening already.
They are now.
Because the cost has come down.
And is it because someone in the family has already been diagnosed, or would they cover the test kind of? And what I'm trying to say to the audience, you don't want to use these tests as a screening. So it's not like you can go and get a mammogram and it's a screening device and the insurance covers that. So that's a whole different thing. This is more genetic testing if you know that your mother had a certain type of cancer and then you want to see if now the family has it. So that's where there's got to be a true risk factor involved. So I also didn't want to start that either. Dr. Villarreal, you are the guy jumping at the bit. Were you always sitting at the front of the class in school?
No, I was usually in the back.
No, I don't think so. You're like, I know, I got it. So what have we not discussed yet? It is, it's passion, it's beautiful. It's a beautiful thing. I meant that as an absolute compliment. What have we not touched base on yet that you'd like to talk about?
Just when we started about the well woman visit and the young woman preparing for pregnancy, just to make sure that she has her vaccinations, especially for measles, rubella, chickenpox, make sure that's all up to date.
Okay.
Yeah, that's very important. And what Dr. Garcia also stated is her vitamins, her folic acid. Go see her doctor prior to the pregnancy, not when she's pregnant.
Not when she's pregnant.
Right.
And even if if you get married, or if you're not even get married, I know that's a whole different thing these days, and it's things I'm not allowed to talk about or supposed to talk about. But just in general, if you want to have children one day and you're a female, just tell your doctor, and that way the doctor, and read up on it. And that's something that I feel is super important. When we're talking about, actually, Dr. Garcia, let's go with you first, because I do have questions here from the audience. But in general, and again, thank you for my baby boy. You weren't around for my baby girl. She's too old. And we used to call you Doogie Howser. He's 16, so you're a lot older now, but you still look like you're 12.
Thank you.
It's a beautiful thing. But in general, it is, yeah? It's all the estrogen. He's around it all the time. What is it that you'd like to talk about before the show wraps up?
The way technology is advancing, we see it all the time in our offices. We're talking about genetic screening. And also, just to bounce off, just continue on this well woman visit, if you're going to go on preconceptual counseling, genetic screening for carrier problems is very important. So
nicely said, for carrier problems, right.
There's a standard panel has 23 carrier conditions that can be screened for, and certainly we can order this on the first OB visit, but it's better to be prepared before pregnancy.
Right.
Because if you do test positive as a carrier for, say, cystic fibrosis,
Right.
muscular atrophy, Fragile X syndrome, hemoglobinopathies, any of these conditions, you should have your partner check too, just to
Right.
see what your risk is for a baby. And just bouncing off of that, once you're pregnant, there's also blood testing now that will use cell-free DNA to determine the risk of the baby having Down syndrome,
Really? Okay.
Patau syndrome, Edwards syndrome, chromosomal problems where the baby can continue to grow and deliver at term.
Okay.
So a lot of chromosomal problems, unfortunately, babies will demise early on, but the chromosomal problems that we see that can continue to grow and deliver at term, like Down syndrome, can be we can screen for with better testing than we've ever had before, using cell-free DNA from the mom's blood.
So when, I'm just thinking now as a person who's walking into your office, and let's just say I am 25, let's just go back to that magic age of 25. Would this be something that you would bring up to the patient of consider these screenings?
Yes.
Or is this something,
The
okay.
genetic carrier screening, yes. That
Okay,
would
and so
be
that's
part
to
of the-
every patient that would come in?
Correct.
Okay,
Along with seeing what their status is for, as Dr. Villarreal mentioned, especially their rubella status, varicella status, more importantly.
okay. So my mother was pregnant with my baby brother, and she had the German measles, so rubella. Sorry, German chickenpox, German measles.
Yeah.
Which one is it?
German measles.
Which,
Yeah,
that can
rubella.
cause a syndrome.
Oh yeah, and I remember how worried he's 5 years younger than me, and as a 5-year-old, you don't know much. You just know that something's going down, and you're just. So that's a beautiful thing. Again, every time we have a show like this, all the different things, and again with oncology, dear Lord, every 6 months there's something brand new, and people's lives being saved in the world of oncology. Absolutely fantastic. Question here from the audience because we still have a little bit of time left. I had a bladder lift 3 months ago. That's something brand new that I am not aware of. And now I get bladder infections often. Could this have been from the surgery, or is this something that I'm doing? Question from the audience. Number one, bladder lift. So you're smiling again. Dr. Villarreal, he's like, God, stop giving them to me.
Again, she has to make sure it's an infection.
Right.
She could still be recovering from the operation. And the
And that's right, it's only
irritation,
3 months.
It could
You're
be
absolutely
from an
right, it's only
inflammatory
3
process.
months.
And you can treat inflammation. There's products out there that you can treat the inflammation with. So she needs to talk to her surgeon. And what Dr. Garcia said earlier, if they diagnose her with a UTI or a bladder infection, make sure they do a culture.
Okay.
Yeah.
And that's so important to do a culture and make sure everything's right. I love that people are listening. This is actually a comment from the audience, and I thank you very much for this because I was ignorant on this. I want to share some information regarding antibiotics in Juarez. The reason that antibiotic use is less rampant now is that you actually do need a prescription at the pharmacy. So that's fantastic. I was not aware of that. So whoever was listening and called that in, thank you for that. And again, I'd like to talk a little bit I'd like to talk more again on antibiotics because I feel like that's such an interlinking issue that we have everywhere. And I know you talked a little bit about, when I say the overuse, it's just when you have an ear infection. And I look at you because you're my baby doc, so I am going to ask you. So let's talk about not pediatrics, but there's an ear infection, there's a throat infection. Again, to be correctly diagnosed is one thing, but I do feel like that it's being thrown out there a lot. Any advice from the three of you on not using so many antibiotics or not being so quick to request, I guess, antibiotics from your doctor? Dr. Salvador, you're nodding your head. So even though you're cancer doc, you get to take this one.
Like both of my colleagues here alluded to it. You need cultures, and a little culture too before you spring into giving antibiotics. In the pediatric population, mothers always feel like they left the doctor's office, they don't have a prescription for antibiotics, they felt like
You're
it
not
was a
gonna
waste
do
of time.
anything? Yeah, exactly.
And most of them are viral. Cultures, getting cultures before you treat. And yeah, we're, in my patient population, we're seeing very resistant bacteria. And patients are in isolation, contact precautions for us, and they're on heavy-duty antibiotics. And perhaps at one point we'll run out of how to treat these.
I was going to say, where do you see that situation in 10 years when really, and it's worldwide, it's not just in El Paso, it's in or America, it's worldwide. How were these super strains of, and we talk about it with the flu vaccination, you know, there's these super strains of this and that and the other. How do we as a medical community stop it? I mean, is that even it's hypothetical,
It's just really
but if there's an
educating the
opinion.
patient, because like you mentioned, sometimes they'll come in, they want an antibiotic. You just have to sit down and take a few extra minutes and tell them, okay, this is really what's causing your symptoms, and it's probably viral, and I don't need to give you an antibiotic.
And then they go away dissatisfied because they feel like you didn't do anything.
Right.
And that's what we have to say to the audience. When sometimes there's nothing done, it's not because people don't care.
Well, you'd be surprised. Patient education goes a long way.
It does. I
Yeah.
agree, and that is the main reason this show exists, is to educate the population of everybody that's out there. Facebook question: my son, who was just born with trisomy, you know what? Yeah, trisomy 21, William Z. Kids.
Downs.
Okay, thank you very much. Myself, the father, okay, so neither myself or the father have Down syndrome, and I know we don't have a lot of time, and you were talking about testing for this, and I guess they're asking what risk factors are, if there are any that we can talk about.
So yeah, the majority of Down syndrome is not genetically transmitted. So
Okay.
only 5% of cases could there be some kind of deletion or version in one of the parents that could lead to an increased risk for Down syndrome. So 95% of Down syndrome is what's called a non-disjunctional event. So basically it's an abnormal division in the cells before there's implantation that occurs. So
Before implantation?
Before implantation,
Okay.
after conception. So
Okay.
it's not 95%, it's not genetic. So, but because this happened already, so anytime we see a chromosomal problem, that does increase the risk of another chromosomal, of having another pregnancy with another chromosomal problem to about 1 in 100. That's
Okay.
just baseline. Now, if the patient's 40 years old, it could be 1 in 80.
Right.
If they're older, it could be 1 in 60, so it just depends.
So the risk factor that we are aware about is age in that point. We are wrapping down the show, so I want to say thank you so much, especially if you were here at the beginning of the show. I appreciate your patience. In 22 years of doing this program, I've never been late, and today, just man, there's all the factors, all the forces of nature were working at the same time. So I appreciate your patience very, very much. And again, this has been a program with Dr. Villarreal, Dr. Salvador, and Dr. Henry Garcia, who, if you know Landenberg Pettit, my kid, it's because of this man. So thank you very much. And again, if you ever have any questions, go see the doctor first. Do not diagnose yourself. That is something we want to talk about. If you want to watch the show again, you can go to kcostv.org. You can find TV schedule and then watch the program. And then you can also go to the El Paso County Medical Society, and that's epcs.com. I'm Catherine Berg. Good night.